Yes, Sandhya, go ahead.
Yeah. A very good afternoon to all of you. I, Dr. Sandhya Meshram, extend a warm welcome on behalf of Twin POJs to all the dignitaries, faculties, and the delegates to yet another webinar in the Cutting Edge series. A famous Sanskrit shloka says, Nasti vidyasamo bandhur nasti vidyasamah suruta, nasti vidyasamam vittam, nasti vidyasamam sukham. That means there's no friend, no companion, no wealth, or no bliss as great as knowledge. And so we all are here to gain knowledge. And the Cutting Edge webinar series surely is an important platform for that. All the much needed topics are explained in a simple and lucrative manner, and that too from the stalwarts in OBGYN. Today's webinar is in association with Gorakhpur and Lucknow Society. So let's start with today's webinar. I request, has Aarti madam joined? I request Meenu madam to please give her blessings and let's start with the webinar.
Thank you, Sandhya. And on behalf of Pune Obstetric and Gynecological Society, I welcome the Lucknow OBGY Society and Gorakhpur OBGY Society, as well as the Food and Drug Committee of Dr. Ritu Khanna. Chairperson, so a very, very warm welcome to all of you.
Yeah.
And I'm very happy to see Dr. Savita Agarwal, madam here, and Dr. Preeti Kumar ji here, Dr. Sadhna Gupta, madam. Huge regards for you, madam. And I also see here our secretary of our society, Dr. Meenakshi Deshpande, and I'm very privileged to have Dr. Vaishali Chauhan with me for this webinar. Every week, 4 to 5, she's there with me and standing like a rock with me for this webinar. So thank you very much, and I welcome all of you to this webinar. And we named it Cutting Edge because we try and incorporate, we make it a mixed bag. So one is with an obstetric, which is like ongoing, ever going, but not changing so much, along with whatever changes we are seeing in day-to-day surgical procedures and protocols. So we add these two and we kind of make it a mixed bag webinar. So that is why it is called a cutting edge webinar. So yes, we can go ahead. Vaishali. Meenakshi, are you there? Yeah, yeah.
Yes. Mr. Prasad, can you play the prayer song, please, for the inauguration?
Yes. Yeah.
Sandhya, please go ahead.
Yeah, a warm welcome to everyone for this cutting edge webinar. And this is, I would like to just say that cutting edge webinars is a brainchild of Dr. Meenu Agarwal. And this webinar we are conducting every Tuesday, 4 to 5 p.m. It is a quest to spread knowledge. We take different topics. Meenu Madam speaks on hysteroscopy or ART or laparoscopy, and we have one more topic on joyful motherhood. We would also like to appeal to everyone. Thank you to all the delegates who have logged in, and this is an appeal from our side, as Dr. Meenu Agarwal, as you know, is contesting for the post of Vice President West Zone, and we also have here Dr. Preeti Kumar, who is also standing for post of Vice President North Zone. So we request all of you to support both our very strong personalities and who are very great leaders of FOXY. and we need wishes from everyone. So for today's cutting edge webinar, we have collaborated Pune Gynec Society along with Gorakhpur and Lucknow OBGYN Society and Food and Drugs Committee Foxy along with Dr. Ritu. And we are truly blessed to have with us such esteemed people, faculty, and Dr. Meera Agnihotri, he is chief guest for today's webinar. She is not well, but Madam has sent her blessings to all of us and for this webinar. So it is a proud privilege for me to introduce none other than a guest of honor, Dr. Sadhna. Madam, as you know, is a great doyen of academics. Madam is highly academic, a big stalwart. And we've been listening to Madam's talks and lectures and orations since many, many years. And Madam, you do have a huge fan following amongst the entire Foxy community. So talking about Madam has been a gold medalist not only at MBBS but at MS, FICOG, FIMCH, FICMU, senior consultant infertility specialist at Jeevan Jyoti Hospital and Medical Research Center, Gorakhpur. Madam has held many positions. She has been co-chair CEPHOG NCD committee, president NIGF, Foxy representative to CEPHOG in 2018-21, vice president Foxy 2016, Foxy past chairperson of Safe Motherhood Committee, ICOG governing council member, ISOPAP, executive board member, chairman of UP chapter ISAR 2017-18, and Madam has received many individual awards and honors. Dr. APJ Abdul Kalam Life Achievement Award in 2023, Economic Award in 21, MS Signature Award in 2023. She has done exemplary community work, Foxy Padma Bhushan Kamla Park Hospit Award, Foxy RN Malhotra Award, Foxy Dr. Durusha Award. She is also recipient of Dr. N.A. and Shailaja Pandit Award for Women Empowerment in 2021. And she has won twice Dr. Savita Rastogi Award for Best Doctor of UP by IMA. Madam has many academic publications and awards, and she has been organizing chair and secretary of many conferences. Madam is truly a highly academic personality, and we respect you, Madam, and we truly admire you. So a warm welcome to Madam, and we request you to give your blessings to us.
Thank you, Vaishali, and thank you, Dr. Meenu and Vaishali and all the team for Cutting Edge for this invite. And when we see and meet everyone on virtual platform in physical, we always see that life is really blessed one, and having friends and association with senior and like grooming juniors, what we have been seeing Preeti as a younger sister in the young life, and the Vaishali as a chair perinatology committee, and it is something that every professional body work hard, travel, and the connectivity that really gives us what we can say it is the crux of the life that we are blessed with such a great teachers like Dr. Meera Agnihotri, our Gorakhpur president, Dr. Savita Agrawal. So it is a such respectful association. We learn from each other, not only the academics, but we learn each other from the life base. So thank you once everyone, Dr. Meenu and Vaishali, especially for this invite. And cutting edge is something which actually put us on the cutting edge, because we are right, we have to be right. A wonderful name, we have to be at the right place. We should not fall down that way and this way. And a wonderful subject you have chosen, because Dr. Meenu, I especially congratulate you, because many times what I perceive that people think that the endoscopy is something like looking at the videos. Yesterday only I read a very good article by Chetan Bhagat that Anshu please chup. This is that the young Indians are like they are learning from seeing videos. And whom doctor you would like? It is a public thing. The doctor who have read through, who have gone experience, or the doctor who have learned from seeing videos. So congratulations to you that you are taking that the topic which we don't want to explore, that is the complication prevention and management. And with our all experience from medical legal issues and NMC, the hysteroscopy is something where we get a lot of patient because suddenly with a little bit of fluid balance and imbalance and the person is sick. So I really congratulate that you are teaching everyone that how to prevent complication and how to manage it. This is very, very important. And the second topic that is by Dr. Ritu Khanna, that is the, please isko insert kar dijiye chart ko. That is the joy of motherhood during intranatal care. So we have come a long way. Once upon we were really heroic thing. Always we used to do the pulse less, BP less, APH, PPH. And now the people are demanding the respectful care from us. The WHO and everybody about what is the positive pregnancy experience. And as a doctor, we are lost that what is meant actually by positive pregnancy experience. So we look forward to great talks and we give all the, like we have to have right on the edge and we should be like responding to the today's challenges and both the topics by the learned speakers. They are really going to benefit everyone. My regards to all chairpersons, Dr. Savita, dear friend, Dr. Babita, friend, she's she's like a younger sister, and Dr. Shyama and Dr. Ashwini. And we look forward to it. And my all the best wishes to Dr. Meenu Agrawal, a highly academician. We have been going together into the conference at the various professional bodies, be it CEPOL, be it ISOPAN, be it FOXY, and also yes, and the Dr. Preeti Kumar, who is going to be always, she walked, today I see she walked the talk, so she is always walking the talk. And I think the Preeti is going to change the way of many things because we were very mild and we were very silently and slow, and the Dr. Preeti is going to change the way of the FOXY in the future, that how one should go ahead. So this is something we learned from our juniors whom we have grown. So once again, thank you, Dr. Meenu, Dr. Vaishali, for this invite, and we look forward to a great session.
Yes, thank you, Sadhna ma'am. This was really dil se. It came from your heart, all the comments that you made about, especially Dr. Preeti and, how she's going to turn the FOXY around. So thank you very much for your kind blessings and for your kind comments, and always smiling, always positive. So I really love meeting you in any conference, whether it is one organization or the other. So it's always nice to meet up with you. Nice to listen to your talks, madam. So very nicely prepared, very well presented talks that you have always. Thank you, ma'am.
Thank you, ma'am. I just wanted to welcome Dr. Aarti Nimkar, our President POGS, because she just joined. Aarti, madam, welcome. I request you, Dr. Aarti Nimkar, to say a few words. Aarti, madam. I think her network is not good. I request Dr. Meenakshi Deshpande to introduce our next
Here, Aarti, madam.
guest of honor.
I joined because I was not unmuted.
Yes.
Can I speak?
Please go ahead, Aarti.
Yes,
madam.
ma'am, please.
Yeah, I welcome you all, the cutting edge faculties and dignitaries and speakers from the Gorakhpur and Lucknow. Our two speakers are there. I know everybody know that Meenu Agarwal madam and Ritu Khanna madam, who is going to speak on the food, drugs and medical legal aspects. And our chairpersons and all the dignitaries from the Lucknow and Gorakhpur. You can go ahead.
Thank you, ma'am. I request Dr. Meenakshi Deshpande, ma'am, to introduce Dr. Preeti Kumar, ma'am, officially, and then ma'am will say a few words.
Yeah, good afternoon, everybody. In this wonderful webinar, cutting edge webinar, we welcome you all the faculties from Gorakhpur and Lucknow to this POGS platform of webinar for safe motherhood, and also for Meenu Agarwal's this thing for vice presidency of Foxy. So I invite Professor Preeti Kumar to this dais. She's a chairperson of Maternal and Perinatal Committee, SAFOG. She's a chairperson of Safe Motherhood Committee, Foxy 2023. And she was a committee member of MFM committee from OFOG from 22 to 24. She was a joint secretary of Indian Justice Chapter 24 to 26. She's presently the joint secretary. And she's a professor and head of Department of Obs-Gynae, Narayana Institute of Medical Sciences, Kanpur. And we all remember how Preeti Kumar madam had come to our Pune for the installation CME, 39th installation CME, and she did a wonderful SAFOG workshop on PPH and safe motherhood. And that is what everybody remembers madam from Pune for you. She was also the organizing secretary of Narshikon, Lucknow Justice 2019. She was the vice president of Lucknow Obs-Gynae Society 22 to 22. She is a core member of Prevention of Violence Against Women Cell of Foxy, recipient of Foxy Late Dr. R.B. S.N. Malhotra Appreciation Award, Foxy Badlao Achiever Award, and I think many awards, Foxy Dhira Award, Shining Star Award, Women Healthcare Award, the Padma Bhushan Kamlabai Hospet Award, Foxy Mr. N.A. Pandit and Mrs. Shailaja Pandit Award, and Foxy Imaging Sciences Award.
Thank you so much.
Appreciation Award by Health Minister also for ensuring safe motherhood in the UP in the year 2020. And she is a society liaison officer for Foxy and FIGO PPH project of UP, India. She is awarded a Woman Inspiration Award by the Inner Wheel Club also. Oh my, quite a few awards, madam. And you are having a lot of feathers in your cap. And we welcome you to Pune and also to POGS, this webinar of Dr. Meenu Agarwal. Welcome, madam.
Thank you. Thank you so much, Dr. Meenakshi. Thank you for your kind introduction. You know, this platform is very, very precious for me. Why this is precious? Because, you know, we have members from POGS who are very close to my heart. I was just mentioning with Dr. Meenu and Dr. Vaishali that Pune Society is very close to me. I think I have an interaction with you, I think, for last 4 or 5 months.
Yes,
and now a lot of
get in
bonding
touch.
and connection with you. Thank you so much for inviting me to Pune installation ceremony. Wonderful memories. Dr. Aarti, I think very silent but very hardworking person. I really admire her. And thank you, Dr. Aarti, for inviting me there. And we had a great time in Pune. So though the stay was, you know, for a shorter period of time, but we had a successful workshop at SAFOG during the conference under the
Many
SAFOG
delegates from
bannership.
Pune remember everything of SAFOG workshop.
Yeah, thank you so much. And the second one is that you are all welcome to Lucknow Society because you are organizing this through Lucknow and Gorakhpur Society. And we definitely have a very strong bonding with Dr. Meenu. And of course, I would like to thank Dr. Sadhna Gupta because I think she was the first one when she was the committee chair of Safe Motherhood Committee to push me in Foxy. She said, no, you have to come, you have to come. So she's like my elder sister and mentor for Foxy, I must say. And I still remember, and I will always be indebted to her for, you know, introducing me to Foxy. So thank you, Dr. Sadhna. Thank you, Dr. Savita ji, for being here. Such a senior person. It's always an honor to be with you. And of course, the blessings of Dr. Meera Agnihotri ji, which is very, very precious for her. Then 2 speakers today, Dr. Meenu Agarwal and Dr. Ritu Khanna. Both of them are excellent speakers. I really love them, hearing them whenever they give talk, and I would love to hear them. And Vaishali, thank you so much for always extending so much of love and affection. Sandhya, a budding star from Pune Society, who wish you all the best. Now, Babita is also one of the very active member of Safe Motherhood Committee, and she also has a very promising future and very dedicated and very hardworking. Regards to my President Lucknow Society, Dr. S.P. Jaiswal, Madam. So I think the topics Dr. Sadhna has already mentioned about the what you are going to speak today. But the only thing is I want to highlight here is that we need to do lot for the community. Maybe I don't know what I'm doing for Foxy, but there is some passion to do something, not to achieve the highest post, but definitely to do something for the society through Foxy platform. So what Dr. Sadhna was talking about, we have incorporated, we are starting G1 project in two of the districts here, that is Fatehpur and Sitapur. They are these districts with high maternal mortality, and we are incorporating respectful maternity care, because these are the facilities who are delivering the babies, but they are not qualified MD doctors. Some are surgeons, some are Ayush doctors. So we need to take the challenge, and we need to train them for the safe motherhood and a joyful motherhood. So these are the things that we need to look at into it, and hopefully we are going to start Jeevan project after I return from AOFOG. So we have almost 22 facilities from Fatehpur and 9 facilities from Sitapur. Hopefully 2 more will be added. It is through UP government and also Japaigo. I have included Charu from Pune Society for the breast problems, and she will be also one of the trainer for that. And definitely Dr. Sadhna ji will be there for some of the training sessions for Jeevan project. So thank you once again for inviting me here for such a prestigious platform. And together we can definitely make a huge difference, but we need to walk together. Thank you so much.
Thank you, Preeti ji, for these nice comments and the huge amount of work that you are putting in. It's not easy. Whatever you are doing, it is huge, and connecting with all these major societies, Japaigos and the world. So some other societies also, I know you are FIGO and others, and CEFOG. So a lot of work that you are doing, and I'm sure once you become the vice president and the president of FOXI, you will take it to another level. So
thank you so much, Dr. Meenu.
Thank you, Dr. Preeti. Truly, you have revolutionized FOXI in a way, Sadhna Madam said. And you have actually taken respectful motherhood, safe motherhood to the grassroots level. And you have really made a change. And you're truly a very dynamic leader. So best wishes to you. And thank you for your presence today and for saying such wonderful words about us. So Sandhya, we are at the end of the inauguration. Can we move ahead with the scientific session?
Yes, ma'am. So now we start with the first session, and the first talk is by none other than Dr. Meenu Agarwal. So for the session, I call upon the chairpersons, Dr. Savita Agarwal and Dr. Babita Shukla, and I request Dr. Vaishali Chavan ma'am to please officially introduce Dr. Savita Agarwal ma'am.
Vaishali ma'am, you're on mute.
Vaishali, you're on mute.
All right. Yeah, sorry. Madam Dr. Savita Agarwal, it's an honor and privilege for me to introduce you and welcome you for this cutting edge webinar. Madam is President Gorakhpur Obstetric and Gynec Society, and she's life member of IMA, FOXI, IAG, and also of ISCCP, UPCOG. And she has served as treasurer, joint treasurer, secretary, vice president of Gorakhpur OBGYN Society. She is also advisor of Hindi Health magazine, Neha, published from Gorakhpur. And she's also worked as secretary, who organized many conferences, workshops, and CMEs successfully. And Madam had organized a very successful workshop on safe abortion in 2001 at Gorakhpur, CME on control of cervical cancer in 2002, and ICOG Zonal Conference on Adults in Health 2002 at Gorakhpur. Madam has presented various scientific papers at AICOG and various conferences, attended various national state level conferences, written articles in Hindi magazines, and she has participated in many rural camps organized by the organization NEHA, that is Nangelia Education and Health Association. Madam has also received many appreciation awards, and on Women's International Day in 2001, she has received award for excellent work in the field of women's health by Gorakhpur Midtown JC branch and Agarwal Mahasabha. Madam, we are truly honored and privileged to have you with us today. So I welcome you, Madam.
Welcome, ma'am. And now I request Dr. Meenakshi Deshpande, our secretary, to please introduce Dr. Babita Shukla. Sorry. to please introduce Dr. Babita Shukla. Meenakshi madam.
Meenakshi? Meenakshi, you are muted.
Am I audible now?
Yeah, you are.
Yes, ma'am, you're audible.
Yeah, okay. Hello. So welcome Dr. Babita Shukla, madam. She is the Vice President of Gorakhpur Obs-Gynae Society. She is the ex-secretary and treasurer. She was the ex-secretary, treasurer and scientific secretary of Gorakhpur Obs-Gynae Society. Presently, she is clinical secretary of ISOPAR Gorakhpur chapter. She is the organizing secretary of SAFOG Saving Mothers Conference 2019, scientific secretary ISOPAR Conference 2021, and secretary of Women's Doctors Association and Mission Pink IMA, I think, Gorakhpur. She is a recipient of many gold medals. She is the ex-vice president of IMA Gorakhpur. Oh, welcome. Directors of Shukla Hospital, director, and active participation in national and zonal conferences as faculty. And she's published papers in many journals. So welcome Dr. Babita Shukla, madam, to our esteemed panel of webinar of PU.
Welcome, madam. And now I request Dr. Savita Agarwal to please officially introduce Dr. Meenu Agarwal for a first talk.
Thank you, Dr. Vaishali, for your kind introduction. And today's topic is the complication of hysteroscopy, its prevention and the management. We all know hysteroscopy is to see the inside of the uterus in various conditions like infertility, abnormal uterine bleeding, postmenopausal bleeding, endometrial polyp and fibroid uterine septum, and the intrauterine synechia and misplaced IUCD. Hysteroscopy is a safe procedure, but sometimes the complication occurs. So, though the complication is in less than 1% of the cases. So, today Dr. Meenu Agarwal will speak on the complication of hysteroscopy, its prevention and the management. It's a very good topic. So, Dr. Meenu Agarwal is the past president of Pune Obs and Gynae Society, elected Secretary General of International Society of Gynecological Endoscopy, Foxy Imaging Science Committee Chairperson 2018 to 2021, Bachelor in Reproductive Endoscopic Surgery, European Board Certified, Course Director Endoscopy and ART Training Course in UAE, over 12 publications in international journals, first author of 4 books and authored many chapters. And she has been awarded India's Greatest Leader by Asia One, Icons of Health by Times Group, Inspiring Gynecologist of West India by Health World, Fox, a champion of Foxy Award. So I welcome Dr. Meenu Agarwal for this talk. So Meenu Agarwal, please go ahead.
You're on mute, Meenu, you're on.
Thank you, madam. Thank you for the kind introduction. And we also happen to share the same surname today. Okay, so I shall be talking today on complications of hysteroscopy. I'm sorry, just one moment. No, okay, all right. All right. Is my screen visible?
Yes, ma'am.
Okay. Thank you so much. Thank you. Thank you, Chairpersons, Dr. Babita Madam and Dr. Savita Madam. And I shall be talking on complications at hysteroscopy, how to diagnose, how to prevent, and then if it does happen, how to manage. Diseases that harm call for treatments that harm less. That means a patient may have maybe a little menorrhagia, or she may be having infertility, or she may be having a postmenopausal bleeding, but she's absolutely comfortable. We cannot do a treatment for her by which she lands up into ICU. So that is very, very important. When we talk about operative hysteroscopy, it is minimally invasive. It is cost effective. It is also may spare a patient a major surgery. Low risk procedure. However, if a complication happens at hysteroscopy, then it can be very severe and it can also be life-threatening. So we know that last decade, we have also heard and about the fatal complications that have happened because some things were not taken care of. Sometimes what happens is the juniors or colleagues, they go to a conference, they see, they don't know that the surgeon who's operating has already put in 15 years of his or her life into doing these procedures. And so we should not jump into doing major procedures when we are learning, when we are beginning to do whether it is a hysteroscopy or a laparoscopy. So what are the 3 levels of hysteroscopy? First level is a diagnostic hysteroscopy with छोटा biopsy लेना है, small polyp remove करना है, you cannot see the copper T thread, you want to remove it, you put a hysteroscope and take it out. So all these small procedures are level 1 procedures. Then suppose you want to do a fibroid, but it is a FIGO 1. It is protruding inside the uterine cavity, or there is a small or a bigger polyp, or you want to do a tubal cannulation. Then it is a level 2. Why it is level 1, level 2? Because these have minimum complications. Then suppose you want to do a septum resection, you want to do any endometrial resection, submucous fibroid, or any ablation. All these are level 3. So whenever we are starting, especially for the beginners, don't jump to level 3. Do 50 cases of level 1, at least 10 to 15 cases of level 2, and then go to the level 3. Then again, the complications which happen, they can be immediate complications, like suddenly patients ko arrhythmias ho gaye, the anesthetist tells you, or uterine perforation, or air embolism, fluid overload, or bleeding. So I shall be taking one after the other. Then late complications. Tomorrow only I am doing one hysteroscopy for one patient who's had a previous submucous hysteroscopic myoma resection, and now she hardly bleeds. When I look at the endometrium, it's only coming till a little bit beyond the isthmus. I cannot see the endometrium beyond that. She wants surrogacy. Surrogacy is not an easy option. So I thought I will do a hysteroscopy, and then if nothing is working for her, then go for a surrogacy. So intrauterine adhesions, any kind of infection, in the subsequent pregnancy, any uterine rupture or any hematometra, post hematometra, especially अगर आपने post menopausal patient में hysteroscopy की है, sometimes then it just again the internal os closes and those patients may come back with hematometra. When we talk about the complications, 100 patients one patient may have a problem, but that one patient can have a very, very severe complication. So that we have to keep in mind. AGL study is very clearly, what did they say? That if you are doing more hysteroscopies in a center or more laparoscopies in a center, then the incidence of complications are lower. Normally we would say कि जहाँ ज़्यादा cases होंगे वहाँ पर ज़्यादा complications, because it is a percentage of the number of cases being done. However, it is not true either for laparoscopy, especially the entry complications at laparoscopy and hysteroscopy complications. These two are lesser in centers where more surgeries are being performed. Perforation, हम लोगों ने सबने, even at the time of our residency, dilatation के time पे, we all have perforated, and it was said that if you have not perforated the uterus, that means you have not done enough number of cases and you are not apt to become to be called a gynecologist. Or we can perforate mechanically with scissors, or you can perforate with a resectoscope, and it contributes to about 60% of the complication. You're doing a hysteroscopy, suddenly you see there is no intrauterine pressure. What could be the causes? Sabse pehle, first thing, again for the beginners, put in a speculum and see whether the fluid is leaking from the side. So that is the most common cause कि आपका intrauterine pressure आपको नहीं अच्छे से, और या distension ही नहीं, it is not happening. Just apply a Valsalm or an Ellis forceps and suddenly you will find that the view is very good. However, if you have perforated, that probably number one will not help. And number two, you can feel it because we all know that you will touch the fundus once you go in. If you are going through and through, you know that you have perforated the uterus. There have been cases where, at the time of hysteroscopic surgery, they have actually pulled the bowel out, omentum has been seen, and a distension of the abdomen. Again, your anesthetist will tell you, madam, suddenly abdomen distend over, please check whether you have perforated the uterus. So all these things are very, very important and we have to keep in mind. You can see here, this is a tiny perforation over here. So, and a laparoscopy can, again, perforation, agar, if you have perforated, say with a dilator, if you have perforated with scissors, you can monitor the patient. You can just, if there is no tachycardia on ultrasound, there is no fluid in the abdominal cavity, like fluid with echogenicity, like a blood in the abdominal cavity or a big clot, vitally patient is stable, you can just monitor and see if she requires a laparoscopy. However, if you want, you can put, just takes an extra 10 minutes, you put in a laparoscope, check out the perforation site, and if need be, just cauterize that place or take a suture there. Suppose resectoscope से अगर perforation हुआ है, then it is very, very important and we have to check immediately. Go with the laparoscope inside. I would do a laparoscopy, but of course laparotomy also can be done because you could have injured the bladder, you could have injured the bowel. So all that has to be seen. And then and suppose हम conservative manage कर रहे हैं and patient has pain or patient has distension or she has tachycardia. So these 2-3 things should be kept in mind, and you have perforated. So you know that this patient needs exploration. How can we prevent? मतलब perforation नहीं हो, what can we do? Procedure under ultrasound guidance. So many a times we keep an ultrasound machine and we go ahead. Now suppose it is severe Asherman. So what I do, under ultrasound guidance, I take a IUI catheter and I put the IUI catheter under ultrasound guidance. So sound also can, sometimes it may not go, but this catheter is soft and it finds its way, and you are doing it under ultra. So you know the rasta. Once you know the rasta, then you can, of course, go with your hysteroscope or with your small dilators, you can go in. Sometimes, especially septum resection by beginners, I think concomitant laparoscope. साथ में laparoscope डालो और साथ में you do the hysteroscopic procedure. That is again a good option. I will tell you how to go about with the electrode, and as I said, any level 3 surgery should not be attempted by the beginners. One good thing I also find that before you do the resectoscope, सबका assembly वगैरह करते हो, उससे पहले just place a office hysteroscope. Patient is under anesthesia already. You have already done a good mapping and everything. And then just see exactly how much you are going to, whether it's FIGO 0, FIGO 1, and you see the base and everything, and then go ahead and do the dilatation. Sometimes, even on ultrasound, it shows a submucous fibroid, and you put a diagnostic and you find that it is actually FIGO 1 or FIGO 2. And you don't want to tackle it hysteroscopically. तो अगर आपने उसको dilate ही नहीं किया, आपने resectoscopy नहीं डाले, then you are not tempted to do anything. You will probably think twice, you will talk to the relatives, and maybe if required, go ahead for a laparoscopic procedure. Whenever we are doing a resectoscope, whenever we are using a resectoscope, always keep the loop under vision at all times. The moment we go up, we should never lose the sight of this loop ever while doing the procedure. So that is, I think, is the most important thing. And always make complete bites. Don't make half bites and leave it hanging. Because then it becomes a little, you don't see it very well, and then you get confused, and you may go higher than the myoma. So these small things we have to keep in mind. Again, suppose we are doing a polyp. It's a simple surgery, level 2 procedure or maybe level 1 procedure. A small tip that whenever you are using a scissors for a polypectomy, always use scissors with one blade moving and one blade fixed. If you are using both blades moving, then there is a very high risk of perforating the uterus. So any procedure which you are doing on the lateral walls or on the fundus, don't use scissors at all as far as possible. On the lateral walls, when you are doing, always use with only one blade moving, because you cannot control both the blades under vision. So that will prevent the perforation. So where would you use the ones where both the blades are moving? Only for the septum or the central adhesions, that if you can see inside the cavity. So there we can use the scissors with both the blades moving. Then again, sometimes when we are entering, so आपका कुछ भी instrument अंदर नहीं जा रहा है, तो what I would probably do, I will go with the hysteroscope, with an office hysteroscope under vision. Once you reach the level of internal os, at that time, increase the pressures little bit. So once you increase the pressures and then take a grasper and just go with the grasper, just open, go there, open the grasper. It will automatically find the weakest point. If you use scissors or if you use a sound, then there is a chance that you can perforate at the internal os. So before you have started the procedure, you have already perforated. So then to prevent that, this use of the grasper, just open it and then rotate it at 90 degrees and again open it. So it will give you a good opening, and then you can place your, then go as an office procedure under anesthesia. Then you can just go inside with a little force, keeping the internal os always eccentric in position. Never keep it central, because it is a 30-degree scope. So if you keep it in the center, you are hitting against the wall and you can again perforate. So always keep it at an eccentric, 6 o'clock, 12 o'clock, depending on where is the ostia, where is the internal os opening. Now, once we are inside, first and foremost is to look for the ostia. If you don't see the ostia, that means you are probably not in the uterine cavity. Come out again and you can again go back, no problem. Again come out and go back into the normal cavity. So you should be able to see both the ostia once you are in the uterine cavity. The second important thing is the fluid overload. You know, we have used monopolar a lot. The current generation is very, I would say, fortunate, I can say, that now they have the bipolar system with them. We used to use glycine, and what we were always worried about using glycine, that whether I am going to cause a problem to the patient, rather than solving her problem. So just a few very, very basic things. First, before you start the hysteroscopy, check what is the mean arterial pressure. Okay, mean arterial pressure is you take the diastolic pressure. Suppose her BP is 110/80. So 80 plus 1/3 of the difference between systolic and diastolic. So 90 will be her mean arterial pressure. Okay, this mean arterial pressure is important. Why? Because your intrauterine pressures should be actually equal to the mean arterial pressure. So again, for the beginners, for the students, they should know why it is so important that the mean arterial pressure has to be noticed. Generally, my anesthetist always writes down what is the MAP of the patient before we start the procedure. The inflow channel and the exit channel are different. Inflow channel on the tip will have an opening. Outflow channels are the holes which are on the side of the tip. So make sure that your inflow and outflow is connected properly. Otherwise, again, you will not get a good distension. So many times we have also, all of us have used this gravity method, we have used this pressure cuff method, we have used. Then of course we have the electronic pump method, which is the ultimate Histromat, that it is called. It is the ultimate system that you could have. You have to just press what you want to do, what procedure you want to do, and it is all with AI that everything is managed. Now, when I say mean arterial pressure, now suppose the mean arterial pressure of the patient is 100, your distension pressure is 100. Okay, what will happen? There is no bleeding, right? Here you can see there is no bleeding. Now, suppose you reduce the pressures, 100 से आपने 50 कर दिया, the vascular channels are open, then you will see the blood coming. Okay. Suppose you have increased the pressure, आपने 150 कर दिया, 100 से MAP. What will happen? Your fluid is going into the vascular channels. And this is very important when you are doing a level 2 or level 3 surgery, where you have gone deep into the myoma, you are into the myometrium, your venous channels are open, and you increase the pressure because you cannot see anything or there is blood. You increase the pressure and all this fluid is getting into the venous channels. So what is the trick? You slightly increase the pressure for a minute. The bleeding stops because your distension pressure is more than the MAP. Then you slightly reduce the pressure. So 150 धीरे धीरे आप उसका कम करो. आप outflow से भी कर सकते हो, inflow से भी कर सकते हो. The moment you see the oozer, the bleeding, do the coagulation. So do not be in a hurry to do the resection. Keep on coagulating. Whenever you see the bleeders, coagulate and then go ahead. So that is the trick. So as I said, if the intrauterine pressures are less than mean arterial pressure, they will be bleeding. If there are more, then the fluid will go in, and you will not believe, within seconds, suddenly the whole fluid is gone into the venous channels. So ideally, the intrauterine pressure should be equal to the mean arterial pressure. And tip of the sensor, which is there in the modern hystromats, it should be in the uterine cavity. Why it is important? Because suddenly if the fluid goes into the open venous channels, the intrauterine pressure will drop, and this will be recognized because the tip of the sensor is in the uterine cavity. It will stop the machine. So it will stop pushing any fluid. So this is AI helping the human errors. Again, when we are using normal saline up to 2000 ml, and if you are using glycine, it is about 1 liter. The anesthetist again should be aware, if there is an increase of diastolic pressure more than 15 millimeters, baseline उन्होंने ले लिया, MAP ले लिया, then they should immediately think कि pulmonary edema तो नहीं है, and immediately look for any signs of fluid overload. You stop the surgery, you check the electrolytes, you give IV diuretics. This is for if the fluid overload with normal saline. Again, AGL guidelines, what they tell us check electrolytes before the surgery. So shortly, immediately prior to the surgery, do the electrolytes, and once you have finished the surgery, again repeat the electrolytes. So this is a very, very important thing that has been the guidelines by the AGL. All right. Again, what is the AGL guideline? कि अगर आप बड़ा केस कर रहे हो, अगर 4 centimeters का आपका सब mucus fibroid which you want to do, you inject about 3 to 4 ml of diluted vasopressin into the cervix. Usse 2 things will happen. The dilatation will become very easy. Secondly, the bleeding is much less. So that, and some people use, paracervical blocks. So that can also be used, and that will help for reducing the bleeding as well as for the easy dilatation. So if you're doing a bigger surgery, time taken. Again, don't get carried away. Always, even AGL guidelines tell us that always counsel the patient for a repeat procedures, step procedure, especially if you're dealing with big myomas. Now, I will again go into AAGL guidelines because they say that suppose we are using glycine, it can lead to fluid overload, hypotonic hyponatremia. Normally, हम लोग क्या बोलेंगे? Postmenopausal women will have more problems as compared to the younger women. Always higher, more age, more surgically at risk. Only in cases of a hysteroscopic surgery, the older women are less at risk as compared to the younger women. Why? Because they have estrogen. The reproductive age woman has estrogen in it, and that estrogen is actually preventing the neurological complications. I will discuss it in the next later guidelines. So this we already discussed. All right. So when I say that the postmenopausal women are less at risk as compared to the reproductive age women. So how do we make the reproductive age women into a postmenopausal woman? We can give GnRH analogs. So very, very strong recommendations when we are doing a submucous fibroid. Use of GnRH analog, 3-month dose Zoladex or 3 monthly depot dose you can give, that will shrink the size of the fibroid, number one. And number two, it will also reduce the absorption because the vascularity goes down and the absorption of the fluid goes down. So, as I said, that counseling for more than one procedure and use of GnRH agonist in premenopausal or the reproductive age women, they become menopausal, right? So they won't have estrogen in them. And that lack of estrogen is actually helpful for the neurological problems. This again I can so when I say there are two types of resectoscope, one is a monopolar, one is a bipolar. So when we talk about a bipolar resectoscope, the current flows from this point to this point. So there is no patient plate, the current is not going through the patient's body. Because it is not going through the patient's body, we can use electrolyte solution, right? Because why we are not using electrolyte? Because it is going through the patient's body in a monopolar. So here we can use a normal saline. It has lesser complication. So all those who are bought or buying new resectoscopes obviously will go for a bipolar resectoscope, but I still have a monopolar and I am still using it sometimes. Infection is very, very rare. Even in suspected endometrial carcinoma, they say if you do it under low pressure, there is enough evidence to show that you can do a diagnostic hysteroscopy in a postmenopausal bleeding, thickened endometrium, very short time, and just go in, take a biopsy, come out under about 50 or 60 pressures. Which are the surgeries at risk? Asherman, very much at risk, because as you go in deeper and deeper into the myometrium, the risk goes up. Myomectomy, placental, retained products of conception, ablation, polyps, septum, and these have very less risk of complications. So this is the Flemish registry which gave. Now, another thing is air embolism. Very important. Air embolism is something nobody should have, right? तो उसके 2-3 रीजन है. Suppose आपका your vascular channels are open, right? And there is a way of the room air to go into the vascular channels. What will happen? The room air will go there. Now, when we are doing any hysteroscopy, there was a very nice paper from Korea, I think, which had come, where they did a transesophageal echocardiography for all patients who were going in for a hysteroscopic, operative hysteroscopy, and they found 60% of the patients had air there. But that is not harmful because that is very minimal and that gets absorbed. However, if the patient is in a trendal head low position में है patient, हम operative hysteroscopy कर रहे हैं, we have those small pieces we want to take out, we remove our resectoscope, we give it to the sister, and we say, give me maybe an ovum forceps or give me a small sponge holder, I want to remove. She goes, she's still finding where the ovum forceps is not kept on the trolley, and you're sitting like that. What is happening in that meantime? All that air is going inside because your cervix is open, your vagina, the vagina is open, and the air has and once it finds an excess, it will keep on going inside. So what is the trick? Whenever you take out your resectoscope, your instrument, always either keep a mop on the vulva or just hold the cervix with 2 Ellis forceps. Never leave it open to air. So that is very, very important. Try and not do the case in a head low position because hysteroscopy you can do in a normal lithotomy position. So what will be the signs? Patient, of course, if she is under spinal, she may complain of chest pain. Suddenly the saturation will go down. Number one. And number two, there will be arrhythmias. So your anesthetist will tell you that there is arrhythmias, the saturation has gone down, and it is so fast that you will not even have time to react. So very, very, very careful. अगर patient head low position में है तो उसको सीधा head up करो, lateral position में उसको दो, and there are, I don't have the personal experience, but the needle can put a needle under ultrasound guidance into the right heart and let the air come out till until it is absorbed. So these are the procedures, but your anesthetist should be aware of this, and how can we prevent it? I have already explained to you. So before the surgery, remove all the air bubbles. Very, very important. These are small air bubbles, but then again, it is better to take the precautions before we start. So lot of training. CMEs, patient selection is very, very important. Again, there are always do a good mapping of the patient, suppose you're doing a fibroid case, so do a good mapping of the patient. That is very important. So just one moment, I'll take this over here. Just I'm finished actually. So just one moment. So what we do at our center, so this is how we have the mapping report of the patient. So fibroid mapping is very important. Now this may appear like a submucous fibroid, but this is a large, it is more of FIGO 2 and FIGO 3. So all this is important. So a good mapping before the start of the surgery is a very important precaution that we must take. And good fluid management system that we should have. Use smaller diameter instruments. तो जो लोग भी अभी begin कर रहे हैं, do it under anesthesia, but entry like an office procedure. So do at least 50 procedures like an office procedure, but under anesthesia. So you get tuned to how to do an office procedure, how to get into the uterine cavity, and that is how you will learn to then do the operative hysteroscopy. Use of an automated fluid management system like a Hystromat. Again, anesthetist should be aware of all the complications, how to manage if there is a complication, close monitoring of inflow and outflow, use of normal saline. And जब भी आप resection कर रहे हो, if you see a vessel, what is the first thing? You increase the flow pressure. The moment you increase the pressure, there is no bleeding and we are very happy. No. That is not the right way. You can slightly increase, but you coagulate the bleeder before going ahead. Your intrauterine pressure should not be more than your mean arterial pressure. Use of intracervical vasopressin, use of preoperative GnRH agonist, and counseling of to the patient to do the surgery in maybe 1 or 2 or 3 stages. All that should be done when we are dealing with the larger fibroids. So thank you very much. And if there are any questions, we can take them. Thank you so much.
That was a wonderful talk, ma'am. You so rightly explained each and every point very meticulously. what could be the complications, how we can anticipate them, and how we can manage them. So, as you said, we cannot do more harm to the patient than the disease she is already having. Hysteroscopic patients are all young patients, and they walk into your clinic, and the attendants are in no way they will accept any complications. And what we see from the medical legal aspect is that the number of cases which are pending in the consumer forum, more number of cases are because of the complications of hysteroscopy. And as ma'am has said, these complications are more common in the younger age group than in the post-menopausal ladies. So the younger population with complications or any morbidity and mortality, it will be very difficult for the attendants to accept it. So we should understand our limitations, our skill. It is a good procedure, very nice procedure. For obstetricians, I mean, for gynecologists, it is like a very handy tool as we have ultrasound. We should definitely go ahead, but then we should be, like ma'am said, start with an office hysteroscope, start with the step 1 procedure, then gradually when you become confident and you are more efficient, then go ahead with it. So the main aim is that you should do no harm. You take your time, you take assistance of your seniors when you start off with procedures, you do a proper mapping and you totally understand the procedure, what, especially in operative hysteroscopy. You should know how big is your myoma or submucous myoma or polyp, and you should do a proper mapping so that you don't land up in a soup in the middle of the procedure. And as ma'am said, like air embolism, that is the most fatal complication. Taking out your resectoscope, putting it again, air bubbles going in. So all these are small tips. Ma'am has very nicely explained that these small things make a big difference. If we take care of it right from the beginning, then yes, we'll have complications are not avoidable, but then we can minimize them to a great extent with our small attempts, and we are careful about it. So thank you, ma'am, for the wonderful talk. If anyone has any questions, please go ahead, or else we call it a great talk.
Thank you, Dr. Babita. Very nicely summarized. So thank you so much.
Thank you, ma'am.
So after the enlightening talk of hysteroscopy from Madam, now let's move on to the next session, which is on intrapartum care for joyful motherhood. And to chair that session, we have 2 esteemed chairpersons. Dr. S.P. Jaiswar, Madam, she is the president of Lucknow Vijayavai Society. She is probably traveling today, so she could not join, but I thought I should mention her name because she has given her blessings for the webinar. And the next chairperson is Dr. Ashwini Kare. I'm extremely happy to introduce an ever enthusiastic and charming personality of POJs. She is a senior, but she is more like a friend. And at present, she is the vice president of Pune Vijayavai Society. She is the chief embryologist of Asha Kiran Hospital and Asha IVF Center, and the centers which are located all over Pune, Arunachal Pradesh, and Hyderabad. She was the secretary of POJs in 2021, treasurer Maharashtra chapter of ISAR in 2018-2020. She was the managing committee member of Maharashtra chapter ISAR in 21 to 23, chairperson of AMOX Young Talent Promotion Committee of 2021 to 23, zonal coordinator AMOX 2018 to 20, peer reviewer of Jogi, which is a journal of Foxy from 2016 till date, and she's received the Foxy Shanti Yadav Award 2022. Welcome, Dr. Ashwini Kare.
Thank you so much, Sandhya, for the kind introduction, and heartiest congratulations, Meenu Madam, for this ever enthusiastic cutting edge webinars that you have been taking tirelessly for about over 2 years now. And I should also congratulate Vaishali Madam, who's your strong right hand, and all our Panchakanyas who are there with you. So proud of you and wishing you all the best for your elections. And I would like to introduce Dr. Ritu Khanna Madam. Can I have a CV, please? So Ritu Madam is currently the chairperson of the Foxy Food and Drug Medico-Surgical Equipment Committee. She is also the National Vice President for Indian Fertility Society and the Central Executive Committee member of Fetal Medicine. And Madam has won all these posts through elections. She is a very silent and a hardworking person, and we have also done many workshops with her committee. She's been awarded the very prestigious BC Roy Award, that is by the President of India. She's got Best Paper Awards, the Foxy DC Datta Award, and the Foxy Achiever Award in 2022, along with the IFS Master Achievers Award. She's got many publications to her credit. Welcome you, Ritu Madam, for this webinar. Over to you.
So I'll just thank you. Ashwin, can I share my screen, please?
So he's very, very soft spoken, very gentle, and very down to earth. So
Yeah, and she keeps working silently. You would never notice that Madam is doing, and she is hosting such a huge conference in Dehradun, not to forget that.
So first of all, inviting all of you to Dehradun and with the theme of resolving dilemmas through newer innovations of women's health. So if anybody has any of the newer innovations, would be most welcome, and we'll be happy to honor the person also and inviting you for this conference. So first of all, my thanks. Thank you, Ashwini, for those very, very kind and loving words. Thank you, Aarti Madam and Meenakshi of POGS Society, so to be having here. And my special thanks to Dr. Meenu, who's so very loving and humble. And Dr. Meenu, wishing you all the best for your endeavors, and I think you're going to come up and we're going to celebrate this. So Dr. Vaishali is, of course, we've had a great association. I think when she was a chairperson, we used to do a lot of activities together, and still on the chit chats also. And Dr. Charu for BSV programs. I think we initiated those programs with Charu, and she's going a great way ahead. And also Dr. Amol. So my also regards to the most admired and the respected Dr. Meera Agnihotri Madam, and the most inspiring Sadhana Gupta Madam. As we said, she's always cheerful, whatever may happen, and she takes you all the way through. And my loving, energetic friend Preeti, if you're there, all our best wishes for you. And of course, I know we're going to rock it. So also thanks to our chairpersons, Dr. Savita Agarwal Madam, Dr. Babita, who's always there with us whenever we need them, and Dr. Ashwini, of course. Yes, and your dynamic, your MOC, Sandhya, really energetic, and you're taking us so well through. So with this, we come to the intrapartum for the joy care, for the joyful motherhood. And I think this is the most important aspect after we've done a dynamic, hysteroscopy and all, and giving her the pregnancy. And now we need to take her through all these efforts which have been done by everyone. So this concept is based basically on the 3 pillars. And that's you provide an optimum pain relief. You give analgesics and antispasmodics. You ensure that the uterine contractions are good, and there's active management of labor, and there is a close monitoring of all the labor events. But this concept came up with the Irish School, and it was dissolved in 1973, and his colleagues said that advantages are there of active management of labor. And what does it do? It results in short labor. So it's going to improve your obstetric outcome, and it lowers the cesarean section. And I think all these are the need of the hour today. And now when managing this mother actively, she's going to be away from all the infections. She's not going to be dehydrated, as she's so tired, exhausted when she's done an exhaustive labor. So she could not develop ketosis, delusion in the mother, and the fetal distress. And we have this beautiful chart of the portogram, which will tell us, when is the line that you need to be on alerts. So, of course, you alert everybody over there. Yes, we need to take an action. And then there is a line which suggests, yes, we are in so much of dilatation. So many hours passed away. So we need to act. So that is how you alert your team over here. Now, everything cannot be applied to everyone. So there is a patient selection. So what are the patients whom you can do a programmed labor? Those patients who don't have a medical obstetric complications. She's a primary gravida, singleton pregnancy, cephalic presentation, and she had a spontaneous onset of labor. If the gestational maturity is 27 to 41 weeks, if the admission NST is reactive and the active phase of labor has already set in. So these are the patients whom you can select. Yes, so any primary who is more than 38 weeks, she's low risk, she's presence of an anesthetist, neonatologist is there, you have to consent of this, and she should be in active phase of labor. But there are certain category of patients where you say, no, you're not going to go for this. And those are the high-risk patients, like those having antepartum hemorrhage or a preeclampsia, diabetes complicating pregnancy, poly or oligohydramnias, If there is a cephalopelvic disproportion, we need not go on trying with a programmed labor or a malpresentation or a premature rupture of membranes. So now we know that we start with the protocol for an intrapartum care only if she's gone into an active labor. But what is that active labor? It's when she has a cervical dilatation of 3 centimeters or more, and the effacement is more than 50%. She's having regular contractions, and the frequency stands as least as 3 per 10 minutes, and they're lasting for around 35 to 45 seconds. The head needs to be engaged, and we are very clear that there is no cephalopelvic disproportion, and the patient may show a draining of the fluid. So then we move out to give her the medications. Now, as per a protocol, we give her a combination. But why do we use a combination? We need to give her an analgesia, we need to give her antispasmodic and all. Why? Because if we use a combination, it's going to benefit because of the drug synergism, while at the same time, you're going to decrease the dose of each of the drug, and therefore she will achieve a progressive labor and your side effects will not be there. So you've done your work of safeguarding the mother and safeguarding the fetus against any adverse effects of the drugs. So that's why you use a combination of the drugs. Now, what do you do when you're starting with a programmed labor? You start with an IV line, and that IV line has to be a 5% Ringal lactate and move on at around 20 drops per minute. We put that drip and we ensured that, yes, she will have her pains of 3 to 4 sustained pains for 10 minutes each. If you find it's not so, it's not moving with a pace, then you add at least 2 units of oxytocin. Or you can give a tablet of Pramiprost orally every hour to ensure that the pains are optimal. And then it is that the progress of the labor will be good. Then you take pentazocine or Fortwin and you dilute this ampule of 30 milligram with a diluent like normal saline distilled water, and similarly a dilute ampule of diazepam in 10 ml of diluent. Now, when you've diluted, you use 1/5 of each of these drugs. That means you're going to pick up 6 milligrams of pentazocine and 2 milligrams of diazepam, and slowly in bolus form through the tubing of the infusion line. So this is what you've done. And what do? You sit and watch the progress of labor. And how do you do that? You're going to chart the maternal and the fetal parameters, for which every hour you're going to do the charting and assess, yes, this is the cervical dilatation, this is the descent. So you're plotting everything on the partogram that we saw before. And when the patient is in advanced labor, the fetal is there pressing on the pelvic floor, and the patient starts complaining of severe pain and breathing down. And it is this time of the cervical dilatation, when you've reached 7 to 8 centimeters, that you give an injection ketamine, which is to be required to be given here. So now, if you go into labor, the proven obstetric analgesia is your epidural. So in places where you don't have an epidural anesthesia, then you can give a tramadol, which is centrally acting, non-opioid analgesic and has been used as a labor analgesic. Ketamine, which you gave her, was a dissociative anesthetic, and that's now gained popularity. Why? Because it gives you excellent pain relief and the patient goes very, very satisfied. So levels of anesthesia, you can assess using your scale as, if the patient has no pain, it's 0. If she has a mild pain, it's 1. If she has a moderate, it's 2. And if she has excellent, then it's 3. So this is how you assess your analgesia. Now let's look into clinical evidence. When they said you compare the patients who have undergone programmed labor with strict criteria of those whom you have selected, you find that the mean duration of the labor will be approximately, it's little less than half, which was required, but the controls was 5.2 and it was 3.5 by the programmed labor. The cervical dilatation was faster, 2.5 as compared to 1.2. The duration of second stage was cut short by approximately half of 26 minutes as opposed to 48. And the duration of third stage was just 3.5 minutes as compared to 15 minutes. And the pain relief, about 60 ml. Excellent, they said 24%, and the perinatal loss was nil. So that means that these are the cases you have selected, and they will, of course, go very well with matching with, not matching, I mean, excelling with the parameters as compared to the controls. So this is a funnel plot, which is plotting the use of, antispasmodics over here versus the control. And they said antispasmodic are going to reduce again the duration of the first stage of labor by an average of 74.34 minutes as compared to the control. So when you've given an antispasmodic, the duration of second again lowers to 2.68 lower. The third stage labor will lower by 0.06 and the total duration by 85.51, which is significant, and cervical dilatation is much better. Now, there was a prospective study which said, let's investigate, valethamate bromide on the length of labor. And they said a single dose of 16 milligram of valethamate bromide was administered intravenously in randomly selected 35 nulliparous, and they said 37 multiparous women too. So the median time for completing the cervical dilatation was 20 minutes in groups which had valethamate bromide and 25 minutes in the group which did not receive it. So the study said that it significantly shortens the second stage of labor in the nulliparous women. And if you compare the side effects of this drug, they said side effects significantly are not statistically significant in those using valethamide as compared to the controls over here. So now they found that let's compare hyoscine, that's Buscopan, with apidocin, which is valethamate for cervical dilatation during labor. And they found that there was no statistical difference, which found when the adverse reactions was compared between the age group of 18 to 25 and 26 to 35. Therefore, the adverse effects reported were irrespective, of the age of the patients, and there were no life-threatening, there were no severe forms of any adverse effects were seen with hyoscine and valethamide during cervical dilatation. And then they said, let's see, still what's the advantage of valethamate bromide over drotaverine? When they looked into more detail of the distribution of cases and the side effects, they said that headache and cervical tear was found to be less in valethamate group than compared to the drotaverine group of patients. So we have a lot of advantages, of the intrapartum care that we've gone through. We saw that it shortens the labor with a substantial pain relief. There's significant amnesia of the painful events of labor, and this is the time I think she's going to remember all her lifetime. So average blood loss was less. The duration of all three stages we've already gone through was markedly less. The obstetric management was literally simplified with all this management, and there was lower incidence of the operative deliveries. And when it comes to the perinatal outcome, it was just similar to those of the control. So an obstetrician, we need to ensure a better life and take her to these joyful moments of her life. And that's what she's going to pen down in her life journey. So thank you so much for a patient hearing.
Thank you so much, madam, for this wonderful deliberation. It was wonderful as always, and thank you for taking us back to the partogram days. So it felt really good to see all this. Thank you once again.
Thank you so much. Thank you.
A lot of practical points, when to give ketamine, when to give epidural, everything. Very, very nice.
Yes. Thank you. Thank you.
Excellent talk, Dr. Ritu. Really enjoyed your talk, and you took us through the various things that are available, which will make it safe, joyful motherhood. Really enjoyed your talk. Thank you, and all the best for your mega event, big conference.
Yeah, thank you. Thank you so much.
Sandhya?
So now with this, we come to the end of today's webinar, and I would request Dr. Vaishali ma'am to please give her vote of thanks so that we could...
Is Dr. Charu there? She was going to join.
Charu was taking a flight when she joined.
I called, ma'am, she wasn't reachable.
Yeah, she must be
He's
the
still in the flight, I
In
think.
the flight.
All right, all right. So thank you everyone, esteemed faculty and all who have logged in today for this cutting edge webinar. And thank you for this is on behalf of Pune Obstetric Gynec Society, Dr. Aarti, Dr. Meenakshi, Dr. Meenu, Dr. Charubape, Dr. Amol Lunkar, and Dr. Sandhya. On behalf of all of us, thank you to Gorakhpur OBGYN Society and Lucknow OBGYN Society for teaming with us and for this very unique webinar. Along with special thanks to Dr. Ritu for not only delivering a wonderful talk, but for associating her Foxy committee with this webinar. Thank you to esteemed our chief guest, Dr. Meera Agnihotri, our guest of honor, Dr. Sadhna Gupta, Dr. Preeti Kumar, and all the faculty chairpersons, speakers, Dr. Meenu. Every time I listen to your talk, I learn more and more. Your expertise is such that truly we had a very enriching experience and a lovely talk. Dr. Savita Agarwal, president of the society. Thank you, ma'am. It was indeed great to hear you, your inputs about the webinar. Dr. Babita Shukla, thank you for being here. And Dr. Ashwini Kare, our very own Vice President of Pune Obstetric Gynec Society. Ashwini, thank you for being with us for this webinar. And special thank you once again to Dr. Sandhya for really organizing, speaking with everybody and coordinating everything. Thank you to BSV and Mr. Prasad, as always, for making everything ready and for facilitating the webinar. So all the best to everyone and thank you to all of you.
And our best wishes, Dr. Meenu, Dr. Preeti, all the best wishes to you.
Thank
And
All
yeah,
the best, Preeti madam, to you also.
yes.
you. Thank
Thank
you.
you, Dr.
Best
Meenu
of luck,
Agarwal, and all
everyone.
the best.
Savita madam for joining and staying. And Savita madam is so senior; she stayed throughout the webinar. So thank you so much for
Thank
that.
Thank you so much, Dr. Meenu Agarwal, and all the best wishes for this.
Ma'am, best
election.
wishes.
Thank you, Dr. Babita ma'am.
We will all campaign for you.
Thank you.
Yes. Yeah. Okay. Goodbye. Goodbye.
Thank you. Thank you.